everyone, welcome to TRI. This is Pack 365, myself Srija. So today in this session, we are going to learn about Chapter 17, that is congenital malformations, deformations and chromosomal abnormalities, which fall under Chapter 17 ICD-10-CM and code ranges Q00 to Q99. And also you are going to learn about Chapter 18, that is symptoms, signs and abnormal clinical and laboratory findings which are not elsewhere classified. So coming to Chapter 17, guidelines. So what does Chapter 17 cover? So this chapter, it includes conditions which are present at birth, even if they are diagnosed later in the life. So the patient is an adult. So if it is congenital, that is from birth, you have to use Q codes, not injury or disease codes. So when to assign Q00 to Q99 code categories? So you have to assign codes from Q00 to Q99 where the documentation shows congenital malformation. So nothing but it's a structural defect. For example, cleft lip, and congenital deformation, shape or position issue due to pressure. For example, club foot, and chromosomal abnormality, which is a genetic disorder. For example, like Down syndrome. So absence of any one of the chromosomes. So they are assigned as secondary diagnosis, principal or secondary diagnosis. So a congenital condition may be the principal or first listed diagnosis, or it may also be a secondary diagnosis. For example, an infant admitted for a surgery to repair cleft palate. So you have to assign Q35.9 as a principal diagnosis. So adult with congenital heart defect admitted for pneumonia. So here in this case, pneumonia is the principal diagnosis, whereas congenital heart defect is the secondary diagnosis. So when there is a no unique code exists, so how do you code? So if a congenital condition does not have a specific code, you have to assign the best Q code available. And you have to add the additional codes for associated manifestations. Next is inherent versus non-inherent manifestations. So what is inherent manifestation? So if the Q code already includes the manifestation, you should not code it separately. For example, Down syndrome is Q90.9. So intellectual disability is inherent in this case. So you should not assign an additional intellectual disability code. So this is how the inherent manifestation works. So coming to non-inherent manifestation. So if the condition causes additional problems but not included in the Q code, you have to assign extra codes for the additional problems. Spina bifida with urinary incontinence is a perfect example for inherent, non-inherent component. So in this spina bifida has a separate code Q05.9, and also you have to assign the additional code for urinary incontinence, that is R32, because urinary incontinence does not included in this Q code. It's a non-inherent manifestation. So you have to assign the code additionally. So what is the additional coding rule here? You should always code separately. What you have to code separately? Complications, symptoms and conditions which are not normally part of the congenital anomaly. So codes from chapter 15, they may be used throughout the life of the patient. So congenital conditions, they do not expire with the age. So even in the adulthood, if the patient still has the congenital condition, Q00 to Q99 codes, they can be reported. For example, a 40-year-old patient with congenital heart disease. So he is still coded with a Q code. So this way you have to code the chapter 17 codes. And there is a condition in which corrected congenital conditions. In this case, how you have to assign? You have to assign the history codes. If a congenital malformation or deformity has been surgically corrected or no longer exists, so you should not use Q codes in this scenario. Instead, you have to use a personal history code from the Z87 category. There is an example, cleft lip repaired in childhood. So you have to use Z87.730 personal history of a cleft lip and palate. You should not use a current Q code because it is not presented the live. So what rules you have to remember? If condition is present now, you have to code from Q category. If the condition has been corrected earlier, then you have to assign the codes from Z, that is history codes. So next guideline is congenital conditions. They may be diagnosed later in the life. So although congenital abnormalities are present at birth, they may be missed at birth. They may become obvious only when symptoms appear later. For example, like polycystic kidney disease, certain heart defects, chromosomal abnormalities diagnosed in the adulthood. So late diagnosis does not change the fact that it is congenital. So when the provider diagnoses the condition, you have to assign Q00 to Q99. Whenever a healthcare provider documents a congenital malformation, deformation, or chromosomal abnormality, you have to assign the appropriate Q code. It applies at any age. So diagnosis timing doesn't matter. Origin at the birth only matters here. So now how do you code for birth admissions? So coding for birth admissions, that is newborn records. So for a newborn's birth hospitalization, the principal diagnosis will be a code from Z38, which is live born infants. So this is based upon the place of birth, maybe hospital, maybe home, etc. And the type of delivery, whether it is a vaginal delivery or a cesarean delivery. And after that, any congenital anomalies using Q00 to Q99. So what is the example now? Live-born infant hospital delivery with spina bifida. So Z38.00 is for live-born infant born in hospital and Q05.9 for spina bifida unspecified. So what is the sequencing rule over here? Z38 must be assigned first, then followed by Q codes. So this is about the chapter 17 coding guidelines. So next coming to ICD-10-CM coding guidelines for symptoms, signs and abnormal clinical and laboratory findings. So what does chapter 18 include in ICD-10-CM? So chapter 18 contains codes for symptoms, what the patient feels, signs in which the provider observes, abnormal clinical findings, abnormal laboratory test results, and ill-defined conditions. So these codes, they are used only when a specific diagnosis has not been established. So what is the important concept over here? If a definitive diagnosis is available, the symptoms should not be coded separately unless guidelines allow it. So what is the use of symptom code first? So when can symptom codes be used? So when the provider has not yet confirmed a diagnosis and when the visit is based only on complaints or abnormal findings, then you have to use the symptom codes which vary range from R00 to R99. For example, chest pain without diagnosis, then you have to assign the code for chest pain R07.9 and fever with no cause identified. Then you have to assign the code fever unspecified, that is R50.9 and abnormal blood glucose R73.9. So no confirmed diagnosis, then symptom code is acceptable. So when should symptom codes not be used? When a confirmed diagnosis explains the symptom, then symptoms code must not be used. For example, diagnosis is pneumonia. So you have to code only pneumonia. You should not code cough or fever separately. So next guideline is use of a symptom code with a definitive diagnosis code. So when is this allowed? You may code both when the symptom is not routinely associated with the confirmed diagnosis. So the symptom provides additional clinical information. For example, like diabetes with unexplained weight loss, cancer with unusual neurological symptoms, and complex syndromes with multiple unrelated symptoms. So if the symptom is integral, which is a normal part of the disease, do not code it separately. And what would be the sequencing rule? Definitive diagnosis code first, then followed by the symptom code. Example, diagnosis is migraine and additional symptom is vision disturbance, which is not a routine part of the migraine. Then you have to assign the code for migraine first, then followed by code for the vision disturbance. Coming to abnormal clinical and laboratory findings. So these are used when abnormal test result is documented. There is no diagnosis is confirmed yet. For example, like abnormal ECG. Then you have to assign code R94.31. Abnormal liver function test. You have to assign the code R94.5. So if the abnormal test leads to a confirmed diagnosis later, so replace the R code with the diagnosis code. So chapter 18 codes, these are often called as temporary codes because they are used for outpatient visits, emergency visits, initial evaluations. So once diagnosis is confirmed, you should stop using R codes. So routine signs and symptoms. So signs or symptoms that are routinely associated with the disease, they should not be coded separately. So unless the ICD-10-CM guidelines specifically instruct otherwise. For example, like diagnosis acute appendicitis. Do not code abdominal pain separately. You should code appendicitis only. So integral symptoms, they are included in the diagnosis itself. Next is combination codes that include symptoms. So what are combination codes first? Single ICD-10-CM codes that describe the definitive diagnosis and the common symptoms associated with it. So when a combination code exists, do not assign an additional symptom code. This is the guideline. For example, hypertensive heart disease with heart failure. So we have a combination code for this. You should not assign separate codes, one code for hypertensive heart disease and the other code for heart failure. You should only assign the combination code. The other example is diabetes with neuropathy. There is a combination code. You should not align separate codes for diabetes and neuropathy. So the symptoms are already built into the code. Next is repeated falls. So repeated falls, this is used when the patient has recently fallen. The cause of the fall is under investigation. And this is used for current encounters. For example, elderly patient with multiple recent falls, cause unknown. So in this case, you have to assign the code R29.6. And history of falling. So coming to history of falling, history itself gives you that you have to assign the code from Z category. So Z91.81 is assigned for history of falling. So this is used whenever the patient fell in the past and is now at the risk of a future falls. So you have to use a history or risk code. So can both codes be used together? Yes, when appropriate. Example, like patient has a history of falls and presents again with recent falls. So for current repeated falls, we will assign the code R29.6 and for the history of falling, we assign the code Z91.81. So next guideline is coma. So coma, R40.20, unspecified coma. This is the code for coma. So when you have to use this code, the cause of coma is unknown or a coma is due to a traumatic brain injury. But Glasgow coma scale is not documented. So when you should not use R40.20 code whenever the cause of coma is known and coded elsewhere. So Glasgow coma scores are again documented separately. You have to use codes in this range for R40.21 to R40.24. So do not code unspecified coma R40.20 for medically induced coma or sedated patient, or you should not code Glasgow coma scale scores. So when the patient is medically induced into coma or sedated. Why? Because the level of consciousness is artificial, but it is not due to a disease or injury. So the next guideline is coma scale. So what are coma scale codes? Glasgow coma scale. So this ICD-10-CM code ranges from R40.21 to R40.24. This is used to record the Glasgow coma scale findings. So GCS has three components. The one is eye-opening, verbal response and motor response. To complete the scale, one code from each category must be reported. So when can GCS codes be used? So this can be used with traumatic brain injury codes. So they are commonly used in the emergency department, trauma cases and ICU documentation. So they cannot be used with R40.2A, that is non-traumatic coma due to underlying condition. So what is the primary purpose of GCS codes? So they are mainly used by trauma registries, but they may be used in any setting where GCS is documented. So what is the sequencing rule for coding coma scale? First, you have to code the diagnosis code and then coma scale codes as a secondary diagnosis. Example like traumatic brain injury. You have to code first. Then you have to add the GCS codes for eye, verbal and motor codes. So you should never sequence the Glasgow coma scale codes as a principal diagnosis. And in this scenario, the seventh character is very important. So seventh character shows when the GCS was recorded. The same seventh character must be used for all the three GCS codes. So what are the common seventh characters used? A for initial assessment, B for subsequent assessment, and C for at hospital discharge. So mismatch of the seven characters occurs, then it is a coding error. So what is the minimum reporting requirement? At least one GCS score must be reported. So to report it. So usually the initial score at presentation and documented by EMT or emergency department staff. So facilities may report multiple GCS scores if they choose. Here is a case and patient with head injury, GCS is documented in ER and patient is not sedated. So what is the correct coding sequence? First is the traumatic brain injury code, second is eye response code, third is verbal response code, and fourth is motor response code, all with the same seventh character. This is how you code the coma scale scenarios. Glasgow coma scale, the total score is R40.24. So when to use R40.24? You have to assign R40.24 only when the total GCS score is documented, only when the individual component scores are not recorded. So if individual scores are documented, you have to use R40.21 to R40.23 instead. So if there is a chance of multiple GCS scores within the first 24 hours, so how do you report it? If there are more than one GCS score is documented within the first 24 hours after admission. So report only the score at the time of admission. So do not code later scores within the same 24-hour period. After 24 hours, ICD-10-CM does not classify coma scores. So they are reported after the admission, but less than 24 hours later. So only admission time score is valid for coding. So who may document Glasgow coma scale scores? GCS, they may be documented by EMTs, emergency department staff, and clinicians other than the attending provider. You have to refer to section IB14 for documentation rules. So GCS does not have to be documented by the physician only. So next guideline is functional quadriplegia. So these are the guideline which is deleted effective October 1st, 2017. So functional quadriplegia refers to severe disability where the patient cannot use all the four limbs due to conditions like advanced dementia or maybe a severe debility, but not due to a spinal cord injury. So since the guideline is deleted, code based upon current ICD-10-CM instructions. So avoid outdated exam material. So next guideline is SIRS, SIDS due to non-infectious process. So what is SIDS? Systemic inflammatory response syndrome. So this can occur without infection. So what are the common non-infectious causes? Trauma, malignancy, acute pancreatitis, and burns. So now what are the coding rules for non-infectious SIDS? First step, you have to code the underlying cause first. For example, like trauma, pancreatitis, and malignant neoplasm. So step 2, you have to add the appropriate SRIS codes. So SIDS without acute organ dysfunction, you have to assign the code R65.10. SIDS with acute organ dysfunction, you have to assign the code R65.11. So organ dysfunction must be documented to use R65.11. So what is the important rule over here? If the infection develops later, coding rules changes. So this guideline applies only when no infection is documented. For example, there is a case where patient with acute pancreatitis develops SIDS. There is no infection and there is no organ failure. So what will be the correct coding sequence? First, you have to code for acute pancreatitis and then SIDS without organ dysfunction. That is R65.10. If there is any organ dysfunction, you have to give the additional code for the organ dysfunction. So when acute organ dysfunction is documented with SIDS of non-infectious origin, you have to assign the code R65.11 as well as assign additional codes for each specific organ dysfunction. So what are the examples of organ dysfunction codes? Acute respiratory failure, acute kidney failure, acute hepatic failure, and acute heart failure. So R65.11, it does not replace organ failure codes. So it is added to them. Provider query requirement. So if organ dysfunction is documented but the cause is unclear, cannot tell if it is due to SIDS or another condition, you should query the provider for classification. So never assume cause and effect relationships unless clearly documented. So next guideline is about death, not other specified. So what is R99? It is ill-defined and unknown cause of mortality. So when can R99 can be used? So in very limited situation only. When a patient has already died or a patient is brought to the ER or healthcare facility and he is pronounced dead on arrival. But when not to use R99, do not use as when a discharge disposition, cause of death for hospitalized patients, and replacement for non-diagnosis. So R99 is not a patient expired. So it is only for the unknown cause of death on arrival, DOA, death of arrival. So next guideline is regarded to NIHSS stroke scale. That is R29.7 code category. So what is NIHSS? It's a National Institute of Health Stroke Scale. So what does it do? It measures neurological status as well as the severity of the stroke. So when can NIHSS codes be used? It is used with acute stroke diagnosis codes from I60 to I63, that is hemorrhagic and ischemic strokes. It should not be used without a stroke diagnosis. So what will be the sequencing rule over here? Acute stroke diagnosis code first and NIHSS code afterwards. So what is the minimum reporting requirement? So at least the initial NIHSS score must be reported. So facilities may capture multiple scores if desired, similar to Glasgow Coma Scale rules. Here is an example. There is a case in which patient with acute ischemic stroke is present in the ER. So NIHSS score documented in ER. So what will be the correct coding sequence now? So you have to assign the code acute ischemic stroke code first, then followed by NIHSS code, that is R29.7 code as a secondary diagnosis. This is about NIHSS stroke scale guidelines. So this is for today's session. I hope the session has helped you. In the next session, you will be able to learn about ICD-10-CM Chapter 19 coding guidelines. Thank you.